Hello and welcome. On behalf of the Southeast MHTTC, thank you for joining us today. We're pleased to continue this discussion around national peer standards with Georgia Mental Health Consumer Network and our panelists. Chris and Heather, thank you so much for being here today and for facilitating this discussion for us.
Heather, would you like to start?
I can. Hi, everybody. My name is Heather James. I'm the Chief Training Development Officer for Georgia Mental Health Consumer Network, and thank you so much for being here. I want to thank our guest, Wendy Tigreen, for joining us for our discussion today, as well as Larissa Guerrero, as we talk today about our national standards with SAMHSA and recovery, and specifically, what does recovery mean to us, and does our personal definition or even the organizations that we work for do their definitions align with what SAMHSA is stating for their definition of recovery? So without further ado, I'm going to pass it off to Chris.
All right. Thank you, Heather. I am Chris Johnson. I'm the Director of Communications for the Georgia Mental Health Consumer Network, and I'm happy to be here with you all today for this discussion. It's one we've been looking forward to, and without much more ado, I want to welcome Larissa Guerrero from the Georgia Council for Recovery and Wendy Tigreen from the Georgia Department of Behavioral Health and Developmental Disabilities. Larissa, would you like to say hello?
Yeah, thanks, Chris and Heather. Hi, everyone. My name is Larissa Guerrero, and I am a woman in long-term recovery. And what that means to me is that hopefully, God willing, October will be 10 years since I've felt the need to use any drugs or alcohol to change the way that I feel. And due to my recovery, I have many opportunities today. I get to be a mother to a sweet little 9-month-old girl. I get to serve as the executive director of the Georgia Council for Recovery. And we do education, advocacy, training, and peer recovery support services across the state of Georgia and some nationally. So I am excited to be here with you all today and looking forward to this conversation.
Thank you so much, Larissa. And Wendy, would you like to introduce yourself?
Hi, everyone. I'm really glad to be back with you. If you were on the previous call, this is a series. And I'm Wendy White Tigreen, and I am with the Department of Behavioral Health and Developmental Disabilities with the state of Georgia, and have been on the team at DBHCD for 30 years. And and I am delighted and honored to have been the principal negotiator, the first partner in writing of the first policy for the peer support service in Georgia, which was the first Medicaid billable peer support service in the country. And that launched July 1st of 1999. So we are celebrating our 25th anniversary of Medicaid billable peer support this summer. And so am delighted to have been subsequently worked with 44 additional states in the building of their peer support programs. So I'm happy as always to be in any place and space with certified peer specialists leading with their lived expertise. So thank you for having me.
All right. Thank you, Wendy. Well, did Stephanie Lindsay sent me a message that she was in the waiting room. Do you know if she made it in? Hey, Lindsay Bailey, you are here. Come join us on the panel if you can. Okay, Lindsay, sit tight. Maybe Stephanie may be having a little trouble adding you as a panelist from the audience, but when she can, we will get there. We're going to start off by just making sure everyone's working from the same information with the, we're just going to look over the overview and standard as they were published by SAMHSA. And Wendy, were you able to get that slide there? And Stephanie, can she share her screen?
Yeah, I've got it ready if there's screen share available.
Yep, go ahead, Wendy. You should be able to share.
Okay, excellent. So folks, what we're gonna just quickly do is to share, just straight from the product, from the national model standards, just the, bear with me one second. I'm gonna move to slideshow presentation mode.
Stephanie, do we have people who are on the phone only that are just listening in?
I believe so.
Okay.
Chris, do you want to read it then?
Yeah, I'll read it as well, but we'll leave it up for just a second. We're going to take a poll. We want to make sure everyone's working from the same definition. It says here, as noted in standard number 1, authenticity and lived experience, recovery associated with a mental health and or substance use condition is a common and critical component of lived experience across the peer workforce. The terms abstinence and abstinence-based recovery describe a historical view on substance use recovery relating to a process of change that includes refraining from the use of all mood or mind-altering substances. This has been interpreted by some to also include some medications used in the treatment of mental health and substance use conditions. While abstinence may be a pathway for some, SAMHSA recognizes and supports the value of medications used in addiction treatment, the existence of multiple pathways of recovery, and the need for a peer workforce that reflects the varying requirements and diverse makeup of the populations being served. In discussions with our expert partners, recovery pathway specific requirements for peer certification were identified as a barrier to expanding and strengthening the peer workforce. And only 2 state certifications were identified as having explicit abstinence specific requirements for prospective certified peers. Through collaboration with our expert partners and analysis of various resources and staying consistent with SAMHSA's working definition of recovery as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential, the following national model standard on recovery was developed. If someone else could read that, I would appreciate it. I can't find my glasses. I'm struggling a little.
I can read it.
I got it.
SAMHSA's National Model Standard on Recovery recommends that recovery pathway specific requirements, including those that are abstinence-based, be excluded from certification requirements. Instead, state certification entities should allow hiring organizations to consider pathway-specific recommendations that meet the needs of the populations they serve.
Awesome. Thank you. So keeping that in mind, we now have a poll question that we just wanted to put out there before we had the discussion. And Stephanie, if you want to go ahead and launch that. Okay. The poll question is, how much do you agree with this statement? After reading the standards, I felt heard and seen as a person in recovery. And the second question is, even though it is a challenging process, it was important for SAMHSA to start this discussion around national standards. If you don't want to answer that question, it's not necessary, but we wanted to have it as a point of discussion, maybe to consider in the chat. If you all want to think about it, and as we're going through, maybe respond to that, that would be great. You can also answer it here if you have an answer. Stephanie, we'll allow them just answer the first question, right?
Sure.
They
Yeah,
submit.
and then
Okay,
questions and comments later in the chat would be perfect.
awesome. Okay, I feel like everyone should probably be done. If anyone needs more time. Okay. That's awesome. I think that's really good. Yeah. Okay. Good. So we will, so Samson did a good job with that. Let's move on. Let's get to, we have a series of questions for our panelists. First of all, and everyone, thank you all for joining us. All 108 of you, welcome. If you have questions throughout, please put them in the chat or in the QA, and we are going to do our very best to follow along with those. Questions are better in the Q&A just because they stick out there. So we will get started with the questions for our panelists. And question number one is, and let's see, Lindsay, are you here in the room with us?
Yes, I am, Chris.
Hi, Lindsay. Lindsay
How's it
is
going?
our, she is the only person on the panel that is not working in the field or connected in any way to this topic, other than she is a person in long-term recovery. And I will let her introduce herself briefly before we go on to the first question, which she will answer first.
So sure. My name's Lindsay Bailey. I'm a person in long-term recovery. For me, that has meant that I've been over 15 years sober from drugs and alcohol that were completely ruining my life, leaving me incapable of amounting to really much of anything. I'm grateful for this discussion because certainly when I got sober, I got sober in an environment where it was very strict about what recovery meant and what it did not mean. And at that time, it did not include for some medications, which later on in my recovery, I found that I personally needed and still felt I was sober. But I think this is a great topic of discussion because not one size fits all. And certainly in terms of looking at compassionate care, we have to meet the individual where they're at, be it harm reduction, be it medication management to help an individual reach their full potential. So thanks for having me here.
All right, thank you, Lindsay. And now if you could answer this question for us, and I think we're going to ask our other panelists to answer it as well. I will answer it as well. But it is, will you please tell us what your reaction was the first time you read Model Standard Number 7, Recovery? And if that has changed, if that first impression has changed since then, how has it changed? Lindsay?
Sorry, I was responding to the chat. Thanks y'all for the congratulations. It's really sweet. For me, when I first read it, at first I perceived it as like, okay, so it's abstinence only or you're not in recovery, which as I kind of mentioned previously, in my own recovery process, I have needed the assistance of medication. You know, I was multiple years in a 12-step program, feeling like I was doing everything that was suggested to me from my peers, you know, and enlarging my spiritual life, as they like to say in those programs, and it wasn't cutting it for me. So to think that the possibility of being told I'm not in recovery because I need a little more additional assistance to help me feel like myself and feel like I am being a productive member of society is harmful for sure.
Awesome. Thank you, Lindsay. Larissa, what did you think the first time you read it?
This is a little nervous about this conversation, but also excited about this conversation because it called out only 2 states have abstinence-based requirements, and Georgia is one of the 2 states. And so at first, my first thought was, uh-oh. And then I thought about it more and I realized we've always considered medication, somebody that uses medication to support their recovery. I've always considered that under the abstinence umbrella. Like I don't see that as something outside of abstinence. So as I was thinking about it more and digging deeper into it, realize, everyone's coming from different perspectives here. And some people might hear abstinence and think, okay, that means that somebody can't be on medication to support their recovery. And so I had that thought about it, what they actually define abstinence as. And we've been having some conversations as we talk to more and more people across the country, and harm reduction is continuing to grow, and the movement is continuing to get more and more momentum. We've been having that conversation about, do we have a requirement? Should we continue to have a requirement for abstinence-based recovery for our CARES Academy? Which right now the requirement is 2 years abstinence-based recovery. Medication counts as abstinence-based recovery. And should we be looking at expanding that? So it was kind of a, we really need to get to having these conversations thought when I read it. So, we don't really do anything quickly. We always take our time and really see what it is that the workforce wants, that the people being served want. We'll do our focus groups and make sure that we're getting plenty of input before making a decision on if we're going to make changes to it, because that would also require changes to Medicaid reimbursement. So my thoughts were a little bit of heart pounding. Oh no, we got to get moving on this, but also, okay, we're still in a good place because we're including medication, but it is something that we need to be thinking about and continue to have these conversations, these tough conversations.
Thanks, Larissa. Heather, did you have anything?
Yeah, I think, when I look at it, I was always kind of going back and forth, as a person who is in long-term recovery, but for me, it's more so mental health versus substance use. I always look at it from a perspective that, especially when it comes to mental health, recovery can look very, very different. And so for me, it made sense that there be kind of an opening to allow for different pathways. But to really be honest with everybody, I really didn't think of it from like the harm reduction perspective with mental health until this past week when I was at SAMHSA for the Power Peers Summit. And I had people talk about their pathway of recovery and how they are following a harm reduction method or model. And for them, that means that sometimes, and full warning, I don't want to activate anybody, but that's for them, they said that sometimes that meant that they would sometimes cut. But for them, that was part of their harm reduction because that meant that they were still able to be alive in the seat today than what the other avenue was. And so when I heard them talk about that, it really just made me kind of sit in my thoughts for a minute and to really think about, okay, what does the recovery look like for every single person? Especially when we talk about mental health recovery in different pathways and certain things being abstinence-based. I know we think about abstinence-based from the substance use, but what about abstinence-based from a mental health? If there are some, self-harming type behaviors going on. What about you, Chris?
Honestly, when I first read this definition, well, the whole idea of standards around self-directed care is something I continue to try to wrap my head around. I mean, I know we have to have them. I feel sort of like we're the like people who plan school lunches. Like we know they should have all of these nutritious things to be ideal, but we know we can't afford that, right? We know that's not practical for everyone. So like, where do we land with this? But just the definition even of what abstinence is, because in the town where I grew up in recovery, like, depending on which meeting you were at, if you were taking this medication or that medication, they considered you sober or not sober, like you were abstinent or not abstinent. And that was just in one town that, didn't even have a target. So like, how do you like do that for a nation? And like, thousands or tens of thousands of communities that have their own standards. And I guess that's what the conversation is about, is creating the national standard by hearing and listening and, being here and doing this work. So I guess I felt hopeful, really, that the conversation was beginning, that the conversation had been happening for a while leading up to the standards, course, they didn't just come out of nowhere. And it was a process, and it continues to be a process. I don't think it's going to end here, like this is it forever. I think we'll move on to something else. But it was a good place to start for sure. Let's move on. I saw a
Yes.
question. Yeah.
Oh, I was just gonna say, if I could offer a bit of a long lens on
That's
this.
great.
I think the interesting thing to me is if I would have read this 5 years ago, or read it 10 years ago, or read it 15 years ago, I would have thought about it really differently. So I really, I think, honor the lenses that everybody just said, and just kind of wanted to reflect that early on, when thinking about evolution, right, of this product of peer support and certified peer specialist as a guild. We introduced, right, nationally it was in Georgia, and then it went national, adult mental health certified peer specialist. And when we introduced the adult, like addiction, substance use condition, lived experience guild, in Georgia is called the certified, peer specialist for the substance use services. We had to start to do some cross training and integrate sub elements in the curricula, so that both those separate curricula address some things that might be a rub to the other. And individuals who were on, psychiatric medications, in many cases, folks were a little bit worried that some of those medications that might, create different types of boosts in the brain system might create certain neurological responses that might be, it mood altering and then play into substance use, right? And we had to really grapple with that for a bit, right? And get to a place where we talked about the science of addiction and recovery in the mental health curriculum, and where we, talked about, just, different, how psychiatric medication in many cases is absolutely life-saving and stabilizing for individuals with mental health conditions, and get comfortable with that difference, and learn to kind of honor and respect that. And then we've had this emergence too of this whole medication assisted treatment model, where in many cases, in order for somebody to have kind of a healthy existence post the use of some drugs, you need to, stay on some type of medication to keep your body physically stabilized in recovery. And so I think that, the opioid, first class of opioid stabilization medications, and then the additional classes that have since emerged, then kind of, I think, have challenged all of our thinking, and we kind of had to sit in that discomfort for a bit. And then I think we've got this dynamic now where we've got, some drugs, marijuana, THC, that are being legalized in some states, not legalized in other states, that are kind of creating this next iteration. So when I read something like this, I'm like, okay, well, that might have gotten out ahead a little bit of the tension spot. We are sitting in this tension spot, but I think it gives us this real chance to do the examination for improvement on what those different pathways are to recovery, and then how we grapple with and settle into certain aspects of this. And again, I think when you talk about it, it's real plain here. They're talking about it from the certification requirements, and you're talking about peerness, right? Even within that group of folks being certified, And so it may be really difficult for folks with kind of certain lived expertise in being abstinent versus some folks who may be, you know, recovering from, you know, a treatment program where you might need an opioid or you need some other opioid, next generation, treatment protocol versus folks who may be, you know, still like recreationally using marijuana. And I think then nationally, this drives us to kind of keep examining though the types of lived expertise and how that specific lived expertise can be used as a tool for other folks' recovery. And so I just wanted to kind of offer that lens as we advance the conversation.
There are a couple of questions in the chat I wanted to pull out. One is from LJ, Lynette James Howlett. I never considered harm reduction and allowing cutting safely. Is that what I'm hearing?
So yes, basically, like I said, I was at a conference this weekend and I'm with Sam said talking about powers of peer and we talked about different variety of topics. One was kind of focused on, you know, diversity, equity, inclusion, but we also talked about the different pathways to recovery, and harm reduction being one of them. And, you know, a person who was on the panel speaking about, you know, harm reduction, you know, they, you know, self-identified as being a person who they still occasionally practiced cutting as part of their pathway to recovery because that meant that they were still alive today. You know, and they, you know, preferences that, you know, they get that is not everybody's pathway, but for them, you know, that was their pathway. And, you know, was it an everyday thing for them? No. Was it like an every week thing? No, it was, you know, maybe once every blue moon, but that was still part of their recovery pathway. And so for me, when I heard that, and then talking about the national standards, we talk about abstinence-based, it just really made me kind of start thinking, you know, because I always thought of abstinence-based in the perspective of substance use. I never thought of abstinence-based in the, you know, within the context of some of, you know, the mental health challenges with some self-harm behaviors such as cutting. And so that one was just an eye-opening to me, really just kind of got my wheels turning as I'm listening at that conference and also preparing for this webinar. So what does that abstinence-based recovery look like? Or what is really, like, how do we define abstinence-based when there's a lot of different things going on for different people?
And that leads us to the next question, which was technical, but I think an important technical question, which is, so is this focused, and this is from Laura Croft, so is this focused on folks who are on MAT, or is this referencing all medications, e.g. antidepressants, mood stabilizers, etc.? I had the same question when I was first reading this, and I then made lots of assumptions and got myself into a comfortable place with my understanding. But does anyone else have a fuller, more precise understanding? So, Laura, I guess we're not going to have a definitive answer for you on that. Maybe we can reach out to SAMHSA and follow up for you, because I'd like to know as well. Because I mean, again, I know I decided that they were just referencing MAT, but based on this conversation, maybe not. Let's see. Was there anything else in the chat or?
I just wanted to say, I think that is one of the, like, it's a very interesting thing. Like even different people can read that differently. So again, I think what you'll hear from the Georgia team is we're sitting around a table together and doing some team collaboration on this. And I'll thank the Georgia Mental Health Consumer Network and the Georgia Council for Recovery, as well as our partner for youth services, the Georgia Parent Support Network. We're just kind of sitting around and processing these together, right? Because they are standards, there's no mandate for meeting them right now. So there's not hard and fast evaluation and regulation tied to them. They've been set forth as a tool for states to advance quality improvement. So that gives local states or local entities a chance to think about them. And that's part of what we talked about last week. But I certainly can see, Laura, that your read on that, like it could be variable. Like I read it like that once, and then as we started talking about like harm reduction in different conferences and different meetings, then I was like, oh, maybe that's more than this. And so I'm with you. It's a little nebulous, as are a couple of the other standards too that we're working through as a team. But again, we're going to come up with kind of, a team-based approach and understanding of these and try to move it forward as a state in partnership with one another. But I think there is a little bit of variability on some of this content, which remains.
And finally, Caroline or Carolyn, whichever, forgive me. The standards absolutely apply to family peers. As from what I understand, all of the standards apply to all of the guilds. So they definitely do. And the absence of the Georgia Parent Support Network here from this conversation should not imply anything at all other than we love them and they're not here. So we meet with them frequently and they're part of our working group. And we are, I hope, representing their thoughts and feelings here, if not their words. But yeah, they're an important part of this process for us, and we're hand in glove in everything we do here in Georgia, but they're not on this call with us today. Is that it for questions so far? I believe it is. Wait,
There was a few more questions.
Okay.
I was just gonna lean in to say, to George's point, so there is a medical office at SAMHSA, of course. There's also a new Office of Recovery. So that is just a little over a year old. And so I think for those folks like in state chairs that I sit in, I find it refreshing that the multiple offices at SAMHSA are trying to like balance one another somewhat and like come to products that I think are super helpful. The 988 office and Crisis Continuum office is relatively new. The Office of Recovery is relatively new. There's the mental health office, there's a CSAT office, there's the medical director's office, the prevention services office. So I'm just really glad that the Office of Recovery has kind of been raised to that level, and that they are staffing up and that they are doing really some great work on some products nationally. And I hope that we can all kind of reinforce how awesome that is so that we can see that balance of recovery services and peer supports being as high and as important and as critical as the medical interventions that the country supports and funds and promulgates. So all I'm answering there for you, George, is my wish, my observations and my wish. But I hope if I speak it enough that it will it will manifest. So
and I will follow up with you with a call to action, which is to support the PEER Act, because the Office of Recovery has not been funded by Congress yet as a recognized body. And which means like in the next administration, it could easily go away if the next, from what I understand, if the next person who ends up in charge of SAMHSA or whatever, like decides it's not of use or benefit or funding. And so we want to make sure that they get to stay. And the PEER Act, from what I understand, makes that happen. Is there anyone on the call who can verify that? Larissa? Well, Heather, you were just there with them. Did they mention the PEER Act at all?
So, I mean, they didn't mention necessarily like the Peer Act. They definitely talked about SOC, and they introduced us to a song all about, SOC, which was fun. Um, but it was they didn't mention that they could be at jeopardy of going away. They really kind of talked about being there to stay. So I don't know for sure, but their priority was really, getting all of us together to hear our thoughts, our perspectives, to give, our recommendations on, how do we expand peer support, especially when it comes to looking at DEI and looking at, how do we make peer support a recognizable, standalone occupation with the Department of Labor, and that we're not kind of under an umbrella term. That was really the point of it. But I can say, just from being there and having the different representatives from the Office of Recovery, from people who were just office workers to some of the like top people within the Office of Recovery that were coming to talk. I love the fact, and it was very refreshing, that they were also people in recovery. And so it wasn't
Screen
just,
sharing, by the way.
so it wasn't just SAMHSA hiring people to work in the Office of Recovery, and they are all like medical professionals or clinicians. It was people who actually have lived experience that were providing their expertise from the lived perspective.
Awesome. Thanks, Heather. And if anyone who knows more about the Peer Act than I do wants to drop it into the chat, that would be great. Okay, let's go on to our second question. Here we are at 1:38. Our second question, would you be willing to share your personal definition of recovery if you have one, and talk a little about how yours aligns with SAMHSA's? And I guess we should probably real quick look back at SAMHSA's definition of recovery, which happens to be on the screen, which is recovery. Is it? Oh, it's not on the screen. Was it on the previous slide?
I will check.
I think it was embedded in that overview. SAMHSA's working definition of recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. So, Heather, you want to go first? How does this align with your personal definition of recovery, if you have one?
So interesting, and to be honest, I feel like my personal definition of recovery sometimes changes on a daily basis depending on where I am. just to be truthful. But for me, really, I just look at recovery for myself as, what am I doing? Like, what am I doing? What tools am I using for my personal life so that I can live the life that I want to live at that moment, in that moment? So that's really how I define recovery for me, because I recognize that the way I want to live my life, it can change. 2 years from now, I can go on a completely different path, and so the way that I approach recovery can change with how I want my life to turn out to be. So that's just, I know it's probably not the greatest answer that you're looking for, Chris, but that's what it is. That's really what recovery is for me. Is what do I need to do? What tools do I need to utilize? Whether it's my coping skills, therapy, taking my medication, whatever it is, so that I can live the life that I want to live at that moment.
Awesome. Thank you, Heather. I mean, mine's pretty straightforward. Mine is just, doing the next right thing to the best of my ability, each day. And sometimes that means change. Sometimes that means stasis. It's just a matter of where I am and what's happening, the world around me and the world in my head, which are two very different places sometimes. But yeah, I think, SAMHSA's definition is, more sort of somehow less broad than mine, but it's, mine's mine. Mine's me. Lindsay, how about you? Well, and by the way, everyone on the call, if you have a personal definition of recovery, we'd love for you to put it in the chat. I would love to see them. Be great. But Lindsay, you want to go ahead?
Sure. I had to really think about this. For me, I feel like what it means to me is convalescence. Like I'm trying to recover from an illness, from unhealthy behaviors, from behaviors that are not serving me well. I feel like that makes it a little more generalized. Because just because I got sober didn't mean I didn't have healing that needed to happen, you know? I had to continue and seek and utilize tools of recovery, therapy, you know, any number of resources there. And like even still, um, you know, I have to recognize too, addiction doesn't always necessarily have to do with a substance. It can, like I mentioned, have to do with an unhealthy behavior. So, you know, even in my own recovery, I've had to become aware of behaviors that were no longer serving me. That, you know, I had the opportunity to change, look at, struggle with. Yeah, I hope that, sorry, I feel like that's a little vague. But yeah, it's just there's a lot to recovery. You know, you recover from using substances, but then you get sober and you might struggle with, you know, eating disorder or sex or self-harm in all of those various types of way, I guess. So I guess it's just like a willingness to look at myself earnestly and honestly and be willing to make changes.
Be willing to make changes. I like that. It doesn't require me to actually change, right? Like the three frogs on the log, right? I want to take a second here before we get to, well, Larissa, maybe you can acknowledge George's definition of recovery that our dear friend Beverly put into the chat for us, because it's a fantastic definition. It's one that the Georgia Council and the Georgia Mental Health Consumer Network, and Wendy, I believe your team was involved in, as well, going around the state and listening to Georgians describe recovery and what their recovery experience was. And after all of those listening sessions around the state, they formulated this definition, and that was back in 2015. And I know one thing that Neil, your predecessor, and Sherry Jenkins Tucker, the predecessor of James Todd, our current Chief Executive Officer, were wanting to do was to revisit, to do a new listening session and see if Georgians still have that same definition, to see if that still fits us. But I wanted to acknowledge let everyone know that if you've never read it, it's worth reading. It's a great definition. But Larissa, go ahead.
Yeah, my personal belief on recovery, what it looks like to me is pretty simple, is the overall quality of my life improving. For me, that happens to mean abstinence. I do take mental health medication, and I did use Suboxone in my early recovery and still consider myself abstinent. So for me, it just means is the overall quality of my life improving. And when I think about it in the context, larger context, I think anybody gets to say when they're in recovery, and they get to define it themselves. So people are in recovery when they say they're in recovery. But yeah, for me, it's just is the overall quality of my life improving. And that doesn't mean that it has to be on a constant upward thing like that, because it certainly goes like this, and I'll get some real low lows and some real high highs in recovery. But overall, my life is a whole lot better than it was 10 years ago, a whole lot better. And with that too, when I think about quality, I think about like the 8 dimensions of wellness. So how's my spiritual health? How's my physical health? How's my financial health, social health, relationships with others? And am I making an effort to work towards those and improving those on a regular basis? And I do thank you again, do want to acknowledge the definition that Beverly put in there. And what I really like about that is how it was determined. So it wasn't just determined by people with degrees in addiction medicine or something like that. It was actually determined by Georgia's communities. So again, Wendy, her team, Neil, Sherry, Larry, all of our historical people in Georgia that really built this recovery movement that we have going in Georgia, Sue Smith as well. They put a lot of effort into making sure that whatever we come up with, it's based on what the community says in the aggregate as a whole and based off of lived experience. So I like that definition that they came up with Georgia. I also like the idea of revisiting that because as we know, and Wendy mentioned earlier, things evolve and change over time. And change, I know for some of us in recovery may not necessarily like it, but it can be a good thing. And we need to make sure that that what we're putting out there and what we're discussing is continually evolving and changing and based on what our communities are telling us.
Thanks, Larissa. I had yeah, I was thinking about that pathway to recovery, the squiggle, when I did the graphic for today's webinar. I don't know if you saw it, but someone asked me about it. They said, Chris, do you think SAMHSA is asking us to compare ourselves to each other? And I said, I don't think they're asking us to. I think that's what a standard does. That's what a standard asks us to do, is to see where we are and to see like it's like, I think it's inherent in the nature of a standard, at least for me, because, I always wanted to be an A student, right? It's like, and I would want my program to be like one of the best. So yeah, I would look at the standards that way, which may of course be why I'm the director of communications today, so I can just talk. It's that definition of recovery as not a straight line, though, it really resonates with me every time I hear it. Let's see. Was there anything in the chat? Were there any questions down there or any definitions that stood out? I read a few of them. They were great. George, you can't spell functional without fun. It's true.
Yeah, we had a couple great definitions that people dropped. Claire Bonnell put, my personal definition of recovery is utilizing a supportive pathway and tools that help me to embrace my most authentic self through self-reflection, emotional, mental, physical, and spiritual balance, while embracing self-love, adaptation/change, and building connection with others to be able to live a full life. Love that one. What are some other ones we have? I see Brittany Williams put, recovery to me is taking one day at a time and giving myself grace, utilizing the tools and skills that I have learned throughout my journey to become the best version of myself, allow myself to acknowledge that I can have bad days and that they do not, sorry, the chat is moving, maybe lost my place. I learned throughout my journey to become the best version of myself, allow myself to acknowledge that I can have bad days and that they do not define me or my recovery journey, and generally loving myself for me and who I am as an individual. So those are a couple of the different definitions that were dropped in the chat, people's personal definition of recovery.
Awesome. Thank you. And thank you guys for writing those, and thank you, Heather, for reading them. That was fantastic. So let me go on to question 3. What do you like about Standard 7 overall? Heather, what do you like about Standard 7?
What do I like about Standard 7? I would say that it's one of those, okay, so it's kind of vague. So I like that it's kind of vague, but I also don't like that it's kind of vague, because sometimes I don't do well with like vagueness and ambiguity. But I do like that it allows for there to be a lot of different interpretations to the meaning of abstinence. Because as we can see with how people talk about what recovery means to them, recovery is different to every single person. Recovery is very personal and very individualized. And so I think when you I think that with SAMHSA saying abstinence space and not really defining that and kind of leaving that open to interpretation by the different credentialing bodies or states. I like that because then those states can talk to their peers, and together those states can figure out what does that look like for their folks, so that they're not causing harm to people that they serve, versus the federal government coming up with their concrete definition that may or may not cause harm to the mass people.
Lindsay, Bailey, how about you? What do you
Sure.
like about it?
Heather, I really like what you had to say. I also think about like, I agree it's very vague, but I do also agree with like, it's based on the individual. I don't know about y'all, but like, I want there to be room for everyone at this table. And because it's so vague, I feel like it allows for people to feel like they still fall into this definition of what recovery means for them. Because, you know, I feel like addiction can be such a lonely state of mind to be in. So feeling like there is a community that they're calling recovery that they feel like they can relate to is so important, just as a community. So I like that it's vague, so that we can basically we have a better chance of meeting an individual where they're at with it being so vague than it being so specific about what it needs to look like.
Thanks, Lindsay. And I'm going to suggest that we use broad instead of vague. Just broad, open, inclusive, like that broad highway. It's instead of limiting. But for me, what I like about it is just that it got the conversation started and that it acknowledged recovery as important, right? It's its own standard. And that to me is huge. It's like if you think about, like when he was talking about the long lens 15 years ago, or even just, when I was introduced to the concept of peer support and recovery in 2015, I had no idea what any of this would have meant, from my lens as just person in 12-step who had, a couple of years under my belt and was providing addictive disease support services at a community service board or public health provider here in Georgia. And I didn't know what this meant. I wouldn't know what this meant. So now I do, and I get to like be a part of this, but just that it's here is huge to me. And that's what I like about it. Who else we have? Oh, Larissa.
Yeah, I like what you all have said already about it. I love the broadness. I'll move to broadness. Love the broadness of it. And I love that they specifically call out multiple pathways to recovery. Because even if two people have very similar stories, maybe they both went to 12-step, maybe they both had very similar paths, it's still entirely different because none of us have the same life experiences. So I really appreciate that they called out multiple pathways to recovery. And then it says in the overview, it says the need for a peer workforce that reflects the varying requirements and diverse makeup of the populations being served. So it's all about diversity and having respect for each other and individuals and their own pathways to recovery. So I like the broadness and the diversity included in it.
Wendy, you have anything?
Yeah, I was gonna reinforce that same point about about that diversity. What I will just sit in, well, 2 points. That diversity to me means a lot more also when you think about the tribal nations around the country and kind of honoring the diversity of what that looks like for them, particularly in the non-traditional kind of medicine realm. And so I really kind of honor not just the diversity we've talked about here in terms of that pathway to recovery, but like, I think our tribal nations have like different kind of cultural context and carry this differently, and we all live together here. So I kind of like that honoring from a national standard perspective. I think the one thing that sits a little unsettled with me, and it's probably because I'm a state representative here, y'all, sorry. I'm the bureaucrat in the house today that got invited to the table, is this definition says halfway down the page that state certification entities should allow the hiring organizations to consider pathway specific recommendations. But I think for me, it's crucial that the state training entities, and I like it locally, the state training entities contemplate and think about this and the pathway specific recommendations. Because I feel like it's at that space where we are creating the guild, right? Like we are creating who's a peer specialist for our jurisdiction. And so for me, I have this level of trust with our training partners, Georgia Mental Health Consumer Network, Georgia Council for Recovery, and Georgia Parent Support Network, and understanding the dynamics of leading that training and the varieties though of training that can also emerge, right? So we do some, different training add-ons like for whole health, forensic lived expertise. And so I don't mean that like we should kind of control that, but I think I feel blessed that we have had these organizations who facilitate all these trainings. And so they're kind of intimately in the know of those cohorts, right? So a cohort comes, they come for training, there's a group of them together, and how that dynamic works together. And if things aren't working well together, then what are the breakouts or breakoffs that might ultimately need to be considered? What makes those dynamic enough to put weight to that? And so I prefer having it at that level than at the hiring entity. I think that could be done just in recruitment. But I still like to have kind of a state lens on that and standard, again, acknowledging the bias as a state director and employee that I bring to the table. So acknowledging that, putting that out there, but also recognizing that I think where training is happening, that is where the skills are being developed and the cohorts being developed in the sense of this lived experience workforce. The very kind of cultural nature of that occurs. And so for me, that is like the sweet spot place and platform where that lands. So that's a little bit of my additional bureaucratic drill down on that specific standard that I offer to listeners today.
Well, and I will add on to that, Wendy, that since we are now moving on to, I think, question 4, what could be better about Standard 7, is that I think there's a general consensus that we want to improve the portability of certifications across state lines, and this limits that. If it becomes employer specific, what the sort of like requirements or standards are, I think then how do you ever know if your credential is portable if it's decided at the employer level, sort of. I didn't really understand that sort of divergence of thinking on that topic that presented itself here. But for me, the thing that I would change is I would make the language more user-friendly, more peer-friendly. I mean, I realize it's a federal standard, but it's a federal standard being written by people who are largely peers, who don't have a lot of experience with legislation and know what some of these, or even a deep buy-in into the sort of work that we do, like when we get down into weeds with this stuff. And I think having like sort of, person on the street friendly version of the standard, and the overview of the standard would be helpful for people and for each of the standards, not just this one, would be really helpful. But I mean, I was an English major, and I get it, I understood it, but I also understand from working with a lot of peers that this would be challenging language for a lot of people who provide peer support, and I don't think that that's the intent. So that's my 2 cents. Heather, what do you think? What could be better?
We'll be like, Chris, am I the first person that you see on your screen?
Oh, sorry.
You're fine. What I think, I agree with you. I think, for any time we have, whether it's SAMHSA, even just like laws that are passed, I think sometimes the issue is that things are written, and it's written in such like jargon or legalese type language that like the average person can't understand it. And we always talk about meeting someone where they are, where if we're creating peer standards, when we're talking about meeting someone where they are, can all the peers read these standards, read this big 30+ page document, and be able to understand it enough to be able to explain it to their coworkers or to the peers that they serve or to their organization. And so I agree with you, Chris. There's just now making the language be easier to read and understand for everybody.
Larissa, how about you?
Yeah, I agree with the language part of it. I think easier to understand is better. Like keep it simple as possible. But I also thank you for saying what you said, Wendy. It gives me a little pause thinking about hiring organizations being the ones making those decisions, because I do worry that the peer voice and lived experience voice might get lost in that. And I say that been at the council since 2016, and I've attended many, many community meetings and have had to stand up at many times and make sure that that the peer voice was at the table when decisions were being made about servicing people in recovery. So I think, not to say that, let me say, there's some great players out there, great, excellent organizations that'll include lived experience in their decision-making process, but there's also some that do not. And I think when lived experience isn't guaranteed at the table, I think decisions can be made that sometimes might cause more harm than good. I also think that that leaving that in the hands, as somebody that has experienced trauma from different organizations that didn't quite understand where I was coming from while I was seeking services, I think there could be a lack of trust in the organizations that are out there providing services. And that goes back to many different historical traumas. And so making sure that, again, people with lived experience have a seat at the table, I think that's essential.
Lindsay, how about you?
I don't know that there's much that I could add. I do agree that simplifying the language would be helpful. But yeah, I really don't. I feel like it's been very well addressed, Larissa. I really like what you had to say. So thank you for sharing that.
Awesome. And I think before we move on, I think we are at the time when we want to open this up to questions from you all. And I would encourage us to, well, we'll start with Glenn Orange. Glenn says, GMHCN has 0 trainings in August and July. Oh, well, no, we had some in July. Can anyone recommend where a noob should start studying this path? Other webinars, reading materials, etc. It's like I have to learn a whole new language for things I've experienced my whole life. I agree with that part. Like, what do these words mean? And then it's like, oh, it's this thing that I've been doing my whole life. Yes. So I'm sorry about that, but Glenn, I think every profession is like that. we all have our jargon, and it's just because I worked on Wall Street, and then I was a college professor, and now I'm this, and I tell you, you have to learn a whole new language every time. But to your point, we may have some trainings in September. We are hopeful. Is that true, Heather, that we may have some in September?
Yeah, so as if you're talking specifically about the certified peer specialist training, we had a training in like towards the end of June, I think going into July. We are still working with the state for our contract. So what we've actually been doing for the month of July, instead of having a training, is looking at our training material and making sure that it is meeting the standards that the state has set place. Looking at the national standards, and then really looking deep at our evaluations that we've received from people to make sure that we are making those changes so that we can bring, this next round of training to the peers, and that it is like the best quality training that we can. We're taking people's feedback and looking at how we can adjust and make the training better to accommodate those who've already gone through it, so that the next cohort aren't experiencing some of the same challenges that others faced. That's kind of what we've been doing right now. But we're hoping to have one in September, but we have had a few webinars. We just did one on problem solving. So we'll continue to post the different webinars that we are, that the agency will be hosting until we get the training dates put in place.
So we should probably answer the rest of the GMHCN specific questions in the comments. And there is one about when the next forensic peer training is. But that applies to not most of the people on the call. So we will try to save that for chat. And I believe I know the answer to that one, but Heather, just in case I don't, if you would take that one. And going up, let's see, I thought I saw a couple other questions up here. I'm mistaken.
A lot of great comments, but I don't see specific.
Did we answer the comments from like the Q&A? I know one was asked like, I think we kind of answered just in general discussion. It says, what role does THC have in recovery in the culture of the CPS profession? Do we specifically address that one directly?
Well, no, I mean, honestly, I think that's one we're tackling as a group of agencies right now. I think especially with the younger generation coming in, where THC is much more widely accepted and widely used, I think. And Larissa, can you tell, is that true that the use of marijuana is going up among youth?
Yeah, that's true, Chris.
So like as people are coming in, and for more people, that I think in some communities they call it the California model, where it's like I'm sober and I smoke pot. And I think we love California. Is that like, how do we adopt or do we adapt to allow for that in our certified peer specialist trainings, or like just where does that land? And I don't think I think we all have our personal responses to you, but I don't know that there is a single response from whomever about how we handle this or how we move forward with it, because it's complicated. It's all complicated, but that one seems especially complicated to those of us trying to have a workforce that is helpful, that identifies with the peers they're supporting. And we're
Chris,
going to continue that.
I thought I would just share one of the dynamics we talked about among the Georgia leadership. And right, that like there's some states who've legalized some of this, some states that haven't. But what we continue to reinforce is that the majority of our providers in our systems have federal funding, and they are working under drug-free workplace rules. And so we, like, regardless, like we're trying to say, if you're going to have like drug testing on the job, how do we talk about that back at the point of certification understanding, because there are these new use trends for young people. There's kind of new perspective on this from state law, from several places. Yet the federal policies still talk about drug-free workplace. And if you test it on a Monday morning, with trace evidence of anything that you were using over a weekend, your job is at risk. And so how to begin to balance those differences in accountabilities that you will be held to on a job. Like, we don't want you to run through a certification program and put comma CPS, certified peer specialist, by your name, but never work. And so I think those are some of the factors like we're really juggling and grappling with, and we haven't landed on anything, but I think that's an interesting point as we are contemplating that new use trend and what that may mean in an agency that's receiving like federal funds, block grant monies, Medicaid funds for substance use or mental health treatment and recovery support. So just a factor that we have in our consideration box, and that we're going to continue to have to struggle with and put some gray matter behind as we try to examine what policies emerge here.
Thanks for that, Wendy. I'm just reading through the comments here. Yeah, and Dylan, I take your point. I do. I have, you know, when I say a workforce that is helpful, I mean, my lived experience is not going to include the history of marijuana and THC that the people in high school now have. You know, it's just a whole different world experience. My worldview of what drugs are, you know, is different than theirs. And I think having people who are in recovery, who share their worldview, but have a like abstinent-based path to recovery right now, is really important for us to be able to identify those peers and to get them trained in the workforce. And that's what I meant. And I'm sorry if I misspoke. I do that.
And Lynette made another, I believe it was Lynette, trying to keep up with the chat. Lynette made another comment about wages, and I'm wondering, Wendy, if you want to speak to that in the Medicaid rate study?
Yeah, I just started typing, so thank you. I will share with folks that that the legislature last year approved a rate increase for not just peer support, but for all Medicaid, and therefore DBHCD is going to mirror this payment. All community mental health and addiction treatment and recovery supports. And the reimbursement rate, based on the rate study and based on what then the legislature approved, is about 33% on average across each of the services. So like we've got like, you know, 40 services, different levels of practitioners in clinic and out of clinic. But in general, when you look across that whole long list of services, the average increase for supports is going up, reimbursement's going up about 33%. So we're very excited for what that means for peer support. And that range runs about 25% to about 38%, I think. Don't hold me on the top number, maybe a little higher. But we are very excited to have that. And the legislature approved a portion of those funds last year, and we're looking for annualization of those funds next year. But that was the commitment from the legislature, that those would be annualized. And we're just very excited because we think it can make a real impact then ultimately on wages. And so then the wage structure, DBHCD can't mandate what certified peer specialists are paid, But we can share the salaries at which that the formula for these rate reimbursements were increased to. And so we're just very excited that there is a significant potential for salary increase with those with the new rate modeling. So look out for additional information on that, but we are just waiting right now. The final step in our process is for federal Medicaid to approve the plan that Georgia has submitted to them. So we are on standby feedback and don't really anticipate any significant challenges to their approval. They're usually happy as long as the state has got the money for it, and our legislature has identified the money for it. So so I'm hoping many of you who might not be working right now might come back in Georgia.
Now, Wendy, where would someone be able to find those numbers, those comp numbers?
Well, tomorrow afternoon, I am doing for Georgians, I'm doing a webinar with the Georgia Parent Support Network to go over some of the math related to that. So you are welcome to join that event, excuse me, and I will try to find the link to that really quickly and put it in the chat before we sign off.
Because that would be good information for people to maybe screen grab and use later in conversations with others. Yeah, it's good information. So any other questions before we move on to our final panelist question? And yes, Wendy, they are Ali Pincus. Is that what's that a URL for, Ali? What is the timeline for Medicaid at the federal level to get back to us?
There's technically what's called a clock with federal CMS, and they get 90 days for review. So the Medicaid state plan was just submitted in the past few weeks. So they have as long as 90 days to get back with us. But we expect with the submission of like a clean plan that can happen a little faster. Oh, thank you, Heather. You were faster than I am because I was trying to answer Allie's question and look for the link at the same time. So thank you. Y'all join tomorrow. Georgia Parent Support Network would be so delighted that we were able to give them a plug here today.
And Allie, just so you know, there is what do you call it? Like there are some organizations like the Georgia Mental Health Consumer Network where that rate increase doesn't actually apply to us because we're just paid from a different trench of money than that comes from. And even though we are ultimately Medicaid funded, it's a different funding stream, and we're not going to get that.
Although it's good for the market.
It's good for the market, and rising tide lifts all boats. So we are excited and championing it. But our paychecks aren't going to change in 90 days. So just
right.
Make sure people hear that. Any other questions up there? Looking.
I don't know if there's CEUs for the webinar tomorrow, y'all. I just agreed to lead it. So I don't know if that's in the body of the detail. Yeah, and the link didn't come across, Heather, on mine. It just said registration link, but I didn't see a link come across.
I just copied and pasted it from the email. Let me try this again. Hold on.
Oh, there it is. It's up above. Thank you. I was looking for it underneath. I got it.
Dylan, I agree. That's why it's important to have the information about what the wage study concluded and what the results of that wage study were when you have conversations with your employer about your own compensation. So yeah, if you're working for a quasi-government agency or subcontractor or whatever it is that won't allow the wage adjustment to impact you, have a conversation. Let's see, We have just a couple minutes left here. Real quickly for our panelists, thank you all for being here today. Lindsay, Wendy, Larissa, especially for taking time out of your days. I know your schedules and you all are busy, busy people. So thank you. But before we go, can you share with us what keeps you hopeful about the future of recovery? Larissa.
Yeah, what keeps me hopeful is that we're having these conversations. It used to be that medication wasn't even, I don't know, my 12-step groups, if you took medication, you weren't allowed to be part of the group, the in crowd. So I'm really hopeful that we're having these conversations and specifically saying that we need to be more accepting to multiple pathways of recovery and diversity as well.
Thanks, Larissa. Lindsay, how about you? What keeps you hopeful?
Sure. Definitely having conversations like this, kind of reiterating what Larissa said, just less exclusion, more inclusion, making space for others with various pathways to recovery. And even, after 15 years, when I meet someone and they say, oh, I'm in recovery, there's just to this day an instant connection, usually just from that shared perspective. So yeah.
Thanks, Lindsay. And before we go on, I would like to hear from everyone in the chat about what keeps you hopeful as well. Heather, what keeps you hopeful?
I think for me, what keeps me hopeful is having these webinars definitely keeps me hopeful that we can just bring so many people from different agencies that come together and we can have these conversations. The fact that here in Georgia, we have GMHCN, Georgia Council, and Georgia Parent Support Network that we meet on a consistent basis to talk about the peer workforce and what we can do as three organizations as a whole to help build it and strengthen it keeps me very hopeful. And I think also the fact that you do have agencies like SAMHSA that are bringing in peers from all over the US to get their feedback on peer specific issues versus them just deciding what they feel we need as peers. I think that definitely keeps me hopeful.
All right, Wendy, what keeps you hopeful?
Oh, yeah, I could just keep on going. I will tell you that I think what keeps me hopeful is the work that certified peer specialists do. And so, I mean, for me, then I have just always been driven to be sure that the policy supports certified peer specialists in being enabled to do their most meaningful work the way that is most meaningful for people who are in need of and seeking and wanting to maintain their personal recovery journey. And so y'all are the secret sauce. Like I do a bunch of plumbing, but every time I'm in a space with certified peer specialist, there's not whining, there is not bickering, there is not negativity, there is great positivity, there's great strength, there's great resilience. And so for me, it's about keeping all of the policy valves and all of the financing valves advancing so that there is more and more secret sauce in the behavioral health sector. And so as long as that secret sauce is flowing and growing, then I have extraordinary hope for just the whole system. And I do want to put a couple of other pins in a couple of things. The 988 crisis continuum just provides an extraordinary opportunity for peer specialists to be engaged when folks are kind of at their most critical point of need. And so just want to keep reminding folks about the roles of peer specialists. when you like that, like we say sometimes in the crisis planning space that the day you're calling 988 or a mobile crisis, or you need a crisis stabilization unit, that's probably one of your worst days. And the hope that certified peer specialists can bring in that moment is just absolutely critical. And then secondly, there's a new kind of model for mental health centers and addiction support centers across the country called CCBHC, and that's Certified Community Behavioral Health Clinic. It's a federal term, so Georgia didn't make that up. It's in on the congressional record. And it allows tremendous growth of agencies who get certified as a CCBHC. And one of the things I want to point out is that it's not in the standard. They've got standards too. It's not in their standard. Well, their standard does require certified peer specialists. That's awesome. But there are other emerging staffing models that say for a team within a CCBHC that supports like 200 individuals in the community, that for every one of those 200 folks that you need 4 CPSs. And 4 CPSs should be on that team. And so I just really want to reinforce that the federal entities are doing a ton of work to like really reinforce the peer specialist role in that position. So I just want to just have y'all keep an eye in those 2 spaces where I just think your critical secret sauce is perfect for, is critical for, and will really have the opportunity to make transformational change. And so keep going with your transformational change. I challenge you. I throw down the gauntlet knowing that y'all will totally pick it up and run with it.
We do every time, and that is what keeps me hopeful today, Wendy, is that, you know, the strengths-based approach we use keeps us going every day. We always do. Next thing we got to do to keep moving it forward, and thanks to Samson and everyone for Standard 7, for all of the standards, and for making this work move forward. We will be back with webinar 3 a week from today, and that one is on supervision. So if you have a supervisor or someone who thinks they're your supervisor, have them come on, because we're going to be talking about supervision. Thank you all, and we hope to see you then.
And there has been a link that has been dropped in the chat from MHTTC. Please make sure that you click it to do the evaluation on the survey for this webinar. Once you complete the survey, you will receive a certificate of attendance. For those who are requesting CEUs, I know if you are CPS MH, you can send a certificate of attendance to GMHC to get approval for CEUs. Larissa, do you want to say what they need to do for the Georgia Council to receive?
If you submit it at the end of the year with your other CEUs, you'll receive credit for it.
There you guys go.
Oh, it says, Allie says that you could get CEUs if you do the evaluation. I don't know if that's for real, but that's enticing.
Yep, but do the evaluation, it'll trigger, it'll produce the certificate of attendance. So, yep.
Bye, everybody.